We now come to that very special part of the meeting where we recognize the outstanding work of our scientists. The WFC Research Awards, sponsored by NCMIC, and the Poster Awards, sponsored by IBCE, are a highlight of the WFC Congresses. To host our 2021 Research Awards, I am delighted to introduce the chair of the WFC Research Committee, Dr. Christine Gertz.
Good morning, good afternoon, and good evening, wherever you are in the world. My name is Dr. Christine Gertz, professor at Duke University. Far more relevant to today's proceedings, I am also the chair of the WFC Research Committee and serve as chair of the Scientific Committee for this Congress. In this role, I have the absolute privilege of spending the next hour with you, honoring this year's recipients of the 2021 WFC Research Awards. Before doing so, it's hard not to think about how much the world has changed since we were last together for this purpose. The previous 21 months have been unprecedented in our lifetime. One result of the COVID-19 pandemic has been to shine a light on science and research like never before. We have seen evidence-based public health efforts to stop the virus spread, the rapid development of effective vaccines, the equally rapid and rigorous evaluation of a myriad of treatments, some of which have been shown to work and some which do not, to the dissemination and implementation of best practices when fighting both the spread of the coronavirus and its treatment. All of this activity has resulted in literally thousands of scientific papers, many of which had to be produced in a very short period of time. Scientists from all over the world have examined every aspect of the pandemic possible. We've seen data gathered from every country, evidence updated on a daily basis, and organizations such as the World Health Organization and the Centers for Disease Control working tirelessly to coordinate and synthesize all of this information to help people, clinicians, patients, the general public, policymakers, and employers make real decisions that impact real lives in real time. It is within this environment that the scientists we will honor today have carried out their work since we last met in Berlin and have generously shared that work with us over the past couple of days. In watching these presentations, the WFC's global commitment to be an epic is clearly demonstrated by the profession scientists who are working tirelessly to develop evidence, formulate guidelines, and collaborate as part of national and international teams, all with their eye on the end users that drive all of this for our work. And by that, I mean patients, clinicians, and the wider public. This year's WFC call for abstracts generated a global response from submissions all around the world. From basic science to public health, educational research to clinical sciences, we're excited to see that our global research community has been so active and was willing to share their work at our Congress. At this point, I'd like to acknowledge the work of my colleagues on the WFC Research Committee and beyond, who served on the peer review committee and did such a great job of reviewing almost 160 abstracts. I'd also like to thank Bright Hall, who coordinated our call for abstracts, and Parker Seminars, who coordinated the research platform presentations and the exhibit of outstanding digital posters, a first at a WFC Congress. It is now my honor and privilege to announce the winners of the WFC NCMIC Louis Portelli Research Awards. We are so grateful to NCMIC's ongoing commitment to supporting our research awards, actually to supporting research in general for all of these years. Dr. Louis Portelli is a past president of the WFC, a past chair of the American Chiropractic Association, and has been instrumental in supporting the profession through the NCMIC Foundation. He has been a tireless advocate of research and evidence-based practice and is the embodiment of the WFC's Be Epic campaign. To qualify for consideration of the prizes, authors were required to submit their full manuscript or poster presentation. The judging panel carefully reviewed each of the entries and made decisions based on a range of factors, including originality of research questions, methodology, and study design, presentation of outcomes, and overall quality. The standard of the entries was high, and the judging committee had a tough time of deciding on the short list and the eventual winners. We are grateful to all of those who submitted entries to the competition. The first of our WFC NCMIC Louis Portelli Research Awards is one that's dear to my heart. It's the New Investigator Award. New investigators are defined as a first author enrolled in a master's or PhD program, or a first author who is within 3 years of obtaining one of those degrees. In addition to the submission of the full manuscript, authors have provided proof of early career status. The winner of the 2021 WFC NCMIC Lou Sportelli New Investigator Award, which attracts a prize of $3,000, is Dr. Casper Glissman-Nim and his colleagues for their paper, The Temporal Stability of Self-Reported Low Back Pain Trajectories. In arriving at their decision, the judges consider this to be a particularly strong study based on its innovation, scientific rigor, and its significance to chiropractic practice around the world. While the use of pain trajectories instead of a standard numeric pain ratings definitely requires more investigation, this study makes an important contribution to our knowledge regarding this emerging topic. Please join me in congratulating Dr. Nim and his team as we share his abstract presentation with you.
Hi, my name is Casper Nim, and I'm a chiropractor and a PhD at the University of Southern Denmark, currently employed at the Spine Center of Southern Denmark. And I will now give my presentation called The Temporal Stability of Self-Reported Visual Back Pain Trajectories. I think we all can agree on that low back pain is a complex condition with many different competing factors. However, if we zoom in the middle, all of them are located around one thing: the pain itself. Now, not too long ago, we thought of low back pain as either having two outcomes. Either this was an acute thing that went into remission by itself over a somewhat short period of time, or we considered it a long-term condition with high persistent pain. However, we know now that's no longer true. In fact, back pain may look more like this. Here we see back pain measured using an 11-point numerical rating scale weekly over a year. And we notice there are large differences between these three individuals. For instance, ID 55 at the top has more episodic pain with some degree of pain-free periods in between, whereas at the bottom, ID 88 has more higher and consistent pain, but still with some fluctuation. And we do see fluctuations in general around all of these three participants. So this information about trajectories may be clinically useful, but unfortunately we have to follow patients for a long time to actually record it. Therefore, the most common trajectories has been translated to these 8 different groups, ranging the low back pain experience from being either episodic, fluctuating, or persistent, and ranging them from mild to more severe in pain intensity. And then finally a group for those who cannot recognize a specific trajectory. So if we go back, this is what the patients actually selected. The first one selected to be in an episodic, in having episodic pain, and the last one, ID 88, chose or selected that he or she had high persistent severe pain. So these trajectories can potentially outline the phenotype of low back pain and can possibly be used as a more nuanced outcome measure in research as well as clinical practice. However, to explore this further, we must first investigate how stable these trajectories are over time. Therefore, our objective was to investigate the temporal stability of individual visual self-reported pain trajectories and by reflecting subgroup differences in pain intensity. Or in other words, we wanted to investigate how many participants selected the exact same trajectory after a year, or how many were strict stable, and how many selected a trajectory which was similar in pain intensity, which we call being weak stable, and how many participants selected something completely different. And to answer this, we obtained data from the SHICO cohort, which is a cohort set in Danish chiropractic practice for low back pain patients reaching out to a chiropractor with a new episode of low back pain. And there was a total of 1,323 participants who had complete self-reported trajectory data at baseline and after 12 months. For the subgrouping approach, we chose to subgroup the trajectories by intensity, ranging from mild to moderate to severe. Now, having a first glance at the data, we see that these trajectories are highly varying and changes substantially between these two time points. In fact, only around 33% of them are strictly stable. However, due to the many different groups available and the high variance that we observe, marginal probabilities, or simply looking at the frequencies, are not sufficient to really examine the stability, as they do not factor in the chance findings. Instead, we calculated conditional odds ratios that did factor in this chance level of staying. Or we calculated the probabilities as independent of the 2 time points, meaning that patients made their choice after a year under the assumption that they did so independent of the choice they made at baseline. Thereby, we looked at the stability odds ratios of being stable, either strict or weak, when considering the overall chance of landing in that same trajectory after 1 year. We also looked at preference odds ratios, which refers to transitioning to a different trajectory given that the patient does not stay in the same trajectory. So the conditional stability odds ratio calculates the odds of staying when considering chance of staying, and the preference odds ratios calculates the odds of transitioning to a different trajectory considering the chance of not staying. And for these strict stable groups, we see stability odds ratios over 1 for all groups, indicating that whatever trajectory the participant enters in, the odds are higher of staying in that trajectory than the chance finding of staying. And these odds ratios increases as the pain becomes more severe. Similarly, for the weak stable odds ratios, here we see increases for all groups. So if, for instance, a patient enters with episodic pain, they have an odds ratio of about 10 of either staying in an episodic character or moving to a trajectory of similar intensity, for instance, mild fluctuating pain. Thus, the trajectories are stable beyond chance. We also looked at the preference odds ratios, and they are presented as heat map, and this can be quite confusing and it illustrates a lot of data, so let's split it up a bit. These 2 squares or rectangles illustrates mild and severe trajectories. And we can observe that there's a tendency that if transitions occurs, they do so between each other, which does make sense considering the weak stable odds ratios that we just witnessed. However, these stable odds ratios didn't tell us anything about that these different trajectory groups actually doesn't move in between each other as often. So for instance, if you have someone with severe fluctuating pain, they likely won't move down to having episodic pain. So the trajectories are stable beyond chance, and transitions to different trajectories occurs to trajectories of similar pain intensity, and transitions between trajectories with different intensity is less likely. So these self-reported visual pain trajectories appear interesting tools to research further, and possibly they can be used as a clinical tool to reassure patients that what pain they're experiencing now, after a year they might experience pain within the same character, and you can illustrate to the patient what they can expect moving forward. And it may provide a more nuanced assessment of low back pain, in research at least. And the preliminary work actually does suggest that using either change data or these self-reported trajectories can optimize prediction models. Finally, and perhaps most importantly, this truly supports the statements made in the Lancet Low Back Pain series that we have to move away from trying to cure low back pain into having to manage low back pain or help people manage low back pain. Thank you for listening. You can find me on Twitter or send me an email if you want to discuss further. And our paper is currently under preparation, but we expect it to be published next year. And as a teaser, I can say that also in the paper we look at how well these transitions to different trajectories are linked with actual changes in patient outcomes. Thank you.
Our next 2 awards are the first and second prize NCMIC JMPT awards. All abstracts accepted for a platform presentation that have not been previously published are eligible to compete for these 2 awards. Contenders for this award have submitted a draft full paper and written consent of all authors to be part of the competition. In addition to receiving the cash prizes, the authors will see their papers published in the Journal of Manipulative and Physiological Therapeutics, or JMPT, where they will be designated as free access, which carries a value of $3,000 per paper. The JMPT is an international and multidisciplinary journal and is indexed in Medline. It is my pleasure to firstly announce the second prize in the NCMIC JMPT category. This prize carries a cash award of $5,000 generously donated by NCMIC. The second prize goes to Dr. Philip Duarte and his colleagues for their paper, Effects of Distinct Force Magnitude of Spinal Manipulative Therapy on Blood Biomarkers of Inflammation and Oxidative Stress in a Healthy Population. In coming to their decision, the judges felt that this was a very important basic science study, which provides preliminary information that may help us better understand the impact of spinal manipulation on important biomarkers associated with the body's immune response. This new knowledge has the potential to open up additional lines of inquiry involving the impact of spinal manipulation on humans. Please join me in congratulating Dr. Duarte and his team as you watch his platform presentation.
Hi everyone, my name is Felipe Duarte. I'm a postdoctoral researcher at CMCC, and today I'm going to present on behalf of this entire research team the results of our most recent project assessing the effect of force magnitude of the spinal manipulation on blood biomarkers of inflammation and oxidative stress in a healthy population. We have no conflicts of interest to report. Spinal manipulation is a form of mechanical therapy, as many others. In a cellular level, mechanical therapy overall works through mechanical transduction. Mechanical transduction means converting the mechanical stimuli into a cellular response. This cellular response can be modulated by different types of mechanical stimulus. For example, if a varying the force that is being employed or the frequency that has been employed can all modulate the cellular response. Continue talking about a cellular level, there is evidence about a crosstalk between mechanical force and neuroimmune system. And this mechanical force crosstalk, it is likely mediated by oxidative stress biomarkers. So oxidative stress biomarkers may be signaling and working in a signaling cascade, mediating the release or the secretion of some of the interleukins or pro and anti-inflammatory biomarkers. Here's an example of a white blood cell and how reactive oxygen species or oxidative stress biomarkers might be signaling this intracellular response. There's also a recent evidence pointing out the role of massage therapy in a healthy muscle, tibialis anterior, and what this study actually demonstrated was a direct relationship between the mechanical load or the load that was employed during the massage therapy and the cellular infiltration. Some of the cells that infiltrated were mastocyte cells or immune or white blood cells. And a very interesting result. And also what was also interesting was that a contralateral effect was observed in this study as well. And the authors suggested that possibly this mechanical event, although locally employed, could be also working systemically. So could be triggering this contralateral response in the contralateral muscle. So lots to investigate here. Talking right now about spinal manipulation and how or the evidence or previous evidence of mechanical load relationship with some of biomechanical outcomes. A few studies observed a direct relationship between force magnitude and vertebral displacement. Also, a direct relationship between force magnitude and distribution of the force on the segment and also adjacent spinal vertebral segments. In addition, Brennan in 1991 and 1992 also observed a direct relationship between force and the release of TNF-alpha and also increase of respiratory burst in mastocyte cells as well. What we don't know is how mechanical force affects systemically the levels of oxidative stress and inflammatory mediators. So then we set up this study to assess the effect of spinal manipulation and force magnitudes. And here force magnitude was defined as a total peak force. We end up recruiting only 19 participants because of COVID. We had targeted to get 33 participants, but unfortunately we only recruited 19. Anyway, we split these participants in 3 different groups. One was like our control group or sham group, receiving only preload thoracic intervention. The second group, 400 newtons total peak force. In the third group, 800 newtons, so kind of doubling the force or the total peak force employed during the thoracic spinal manipulation. So we collected blood before and after spinal manipulation, and because we aim to assess the effect of the spinal manipulation on these blood biomarkers, we did a calculation of the change score, and the change score was defined as a post-intervention and 20 minutes post-intervention subtracted by the pre or baseline values. In order to assess the difference between these 3 groups, we did a one-way ANOVA. Out of the 14 cytokines assessed in this study, we found a significant difference in interferon gamma, interleukin 6, and interleukin 5. Interleukin 6 has both anti and pro-inflammatory role. Interferon gamma usually has a pro-inflammatory role, and interleukin 5, it is still not clear, but apparently has an anti-inflammatory role as well. And these cytokines were increased after 800 newtons spinal manipulation compared to 400 and control intervention. We also assessed, we found an increase on TOS, which is total oxidant status, in plasma, lipid peroxidation, and lipid hydroperoxide, which are kind of like a cellular damage biomarkers, although they can also be signaling biomarkers. So I'm gonna speak right now about the conclusion here and some of the limitations that we still don't know the implication or the clinical implication of the results. Unfortunately, this study was highly affected by the sample size and by the COVID. We only assessed the total peak force. We did not track any other force time characteristics. So we also don't know about the impact of other biomechanical characteristics of the spinal manipulation, such as force rate. And we did not target a specific white blood cell, was kind of an overall reading of the blood inflammatory cascade. In terms of our conclusion, we found that some of the biomarkers assessed were affected by distinct force magnitudes, which is very interesting for us, while the clinical value and the implication of our findings definitely require further studies. We for sure advanced of our understanding of the linkage between spinal manipulation, force magnitude, and blood biomarkers. Here are the references, and thank you very much for your time and your attention.
I'm now thrilled to announce the first prize in the NCMIC JMPT category with a check for $7 $500, again generously sponsored by NCMIC. The top award in this category goes to Michele Maiers and Mary Forte for their paper, Association Between Psychosocial Parameters and Response to Chiropractic Care Among Older Adults with Chronic Low Back Pain. In arriving at their decision to award this first prize in the NCMIC JMPT Award category, the judges noted that this rigorous study focused on an incredibly important patient population where significant gaps in knowledge remain related to chiropractic care, older adults. Further, they felt that the study findings were highly relevant to clinical practice with the potential to impact chiropractors and chiropractic patients around the world. The more we learn about the link between psychosocial parameters and pain, the clearer it becomes how important understanding how issues like self-efficacy and fear of movement can impact chiropractic practice. This is especially critical in older adults with low back pain. Thanks to the work of Dr. Maiers and her team, we now have further evidence of the importance of chiropractors in embracing the biopsychosocial model of spine care. Please join me in congratulating Dr. Maiers and her team as you watch the platform presentation for this award-winning paper.
Hi, my name is Michele Maiers, and on behalf of my colleague Mary Forte, we would like to present an association between psychosocial parameters and response to chiropractic care among older adults with chronic low back pain, a secondary analysis of a randomized clinical trial. And neither Mary nor I have any conflicts to disclose, but we would like to acknowledge Northwestern Health Sciences University for their support of this study. It's well acknowledged that psychosocial factors affect adults with spine-related pain and disability. We know that they influence not only experience of back pain, but also clinical care outcomes. Self-efficacy, a person's confidence in their ability to complete daily tasks while they're in pain, and kinesiophobia, a fear of pain with movement, have been associated with back-related disability in adults, but the impact on older adults is less well understood. Now, our team conducted a randomized controlled trial that compared 12 versus 36 weeks of a combination of chiropractic spinal manipulation and recommendations for at-home exercises. And we found no between-group differences in our primary outcomes, back and neck-related disability at 36 weeks. However, 40% of our sample achieved clinically important reductions in low back disability by week 12. We also noted that the folks who received 36 weeks of care had greater improvements in self-efficacy, functional ability, and balance. And we know from qualitative interviews embedded in the randomized controlled trial that participants really valued a sense of greater self-efficacy that they gained in the study and the enhancements in functional ability. So that led us to wonder whether the initial self-efficacy and kinesiophobia and changes in self-efficacy and kinesiophobia were associated with response to treatment. So we decided to conduct this secondary analysis of the RCT data, which was approved by the IRB at Northwestern Health Sciences University. Again, our population were older adults, people aged 65 years and older, who were community dwelling and had a history of low back pain and disability at least 12 weeks in duration. Our participants were English speaking, cognitively intact, and able to ambulate without the use of a cane or a walker. They also had to have had no contraindications to chiropractic spinal manipulation or exercise to participate in the trial. And again, our intervention was a combination of chiropractic spinal manipulation and recommendations for at-home exercises. And everybody in this secondary analysis received those two treatments for 12 weeks. Our primary outcome of interest was at least a 30% reduction in the Oswestry Disability Index at 12 weeks. And we considered those folks to be responders to our study intervention. Our predictors of interest were both baseline and change scores through week 12 in self-efficacy, measured by the Pain Self-Efficacy Questionnaire, and kinesiophobia, measured by the Tampa Scale of Kinesiophobia. We used several different analytical methods to answer our research question. We used descriptive statistics to describe our population, chi-squared analysis to compare the proportion of responders to the proportions of participants who received greater than mean changes in self-efficacy and kinesiophobia. We also used logistic regression to explore the association between predictors and responders for baseline scores, and then again for the proportion who achieved change in self-efficacy or kinesiophobia greater than the group average. Univariate analysis tested for associations with several variables suggested in the literature to influence response to care, and multivariate analysis included predictors from the univariate analysis. We ended up with a total of 176 adults for whom we had complete data through weeks 12. Our average age of participants was 71 years. The majority were female and reported moderate levels of low back pain and low back related disability. The average duration was 14.5 years of some back-related complaint. They were also relatively high functioning with low levels of kinesiophobia and relatively high levels of self-efficacy. And 69% of our participants demonstrated at least one functional ability disability in our objective short performance physical battery test. So we had a total of 72, or just over 40% of our study participants met that 30% reduction in Oswestry Disability Index. Again, those were the people we considered to be responders to care. And among the sample, the average low back disability decreased from generally moderate to minimal disability. We also saw improvements in pain. Kinesiophobia improved by 5.9%, and self-efficacy improved an average of 8.3%. And we found that adults who met that threshold of being a responder to care, 30% improvement in ODI, were also more likely to have improvements in their self-efficacy that exceeded the average of the population. They were also more likely to have reductions in their kinesiophobia that exceeded the average of the group. When we took a look at our first regression analysis, again, we used baseline self-efficacy, severity, and duration in the multivariate logistic regression. It showed that baseline self-efficacy and severity were no longer significant when duration was included in the model. Chronicity was inversely associated with the likelihood of being a responder. Compared to adults with back pain of less than 4 years, which was our reference quartile, those with back pain duration greater than 14.5 years were 67% less likely to be responders to treatment. And we observed a relatively stepwise negative effect of pain duration on achieving that clinically important reduction in disability at 12 weeks. When we look at our second multiple logistic regression model, which included the percent change in self-efficacy and kinesiophobia, it showed us that adults with self-efficacy of improvement greater than the median were 1.9 times more likely to have responded to care than people with lesser or no changes in self-efficacy. Kinesiophobia and pain severity were not associated with being a responder to care in the full model. And again, in this model, chronicity decreased the likelihood of being a responder. So there are several limitations in this study. First, this is hypothesis generating. The study was not powered to measure the relationships that we explored in this secondary analysis, nor were treatments designed to impact self-efficacy or kinesiophobia. We had a relatively high functioning sample of older adults, and the results of this study might be considerably different with older adults who experience greater degrees of kinesiophobia or have lower self-efficacy. And while our sample actually met the minimally clinically important difference for adults with self-efficacy and kinesiophobia, we actually don't know the appropriate threshold for people over the age of 65. So a few key takeaways. Among older adults, baseline self-efficacy and improvements in self-efficacy and kinesiophobia were individually associated with clinically important reductions in disability, although not in multivariate models when duration was included. The duration overrides the association, especially as participants become more chronic. An important finding from our original randomized controlled trial is that these psychosocial factors were modifiable in chronic older adult population. And future research should consider exploring whether these interventions or other interventions that focus more heavily on self-efficacy and kinesiophobia are important factors for mitigating low back disability in older adults. Thank you.
Our final award in the WFC NCMIC Lou Sportelli Research Awards is the Scott Haldeman Award for Research Excellence. The award is the highest research accolade that the WFC has the power to award and recognizes outstanding work in the field of chiropractic research. Winning authors are free to publish their work in the journal of their choice. with the expectation that the award will be acknowledged in the published paper. The award considers originality, study design, methodology, presentation of outcomes, and the overall quality of the work submitted. It gives me huge pleasure to announce that the winner of the 2021 Scott Haldeman Award for Outstanding Research and a check for $10,000 goes to Dr. James Wheaton and his colleagues for their paper, Utilization of Chiropractic Care Reduces the Use of Prescription Opioids Among Older Medicare Beneficiaries with Spinal Pain. In coming to their decision to award this paper the top research award, the judges were influenced by a number of factors. As we all know, opioid overuse is a huge public health issue and often associated with musculoskeletal pain and disability. The paper involved a very significant data set and directly evaluated the impact of chiropractic care, looking at outcomes that are highly relevant to future chiropractic care provision as a treatment option. The judges were impressed with the quality of the paper, the scientific rigor demonstrated, and the potential that once implemented into clinical practice, the role that these outcomes could have in advocating for an improved scope for chiropractors around the world. This year's recipient of the Scott Haldeman Award for Outstanding Research, Dr. James Wheaton, is unfortunately unable to be with us in this virtual platform, but please congratulate him and his team as we watch the platform research presentation of this award-winning paper.
Good morning. I'm Jim Wheaton. I'm a researcher at Southern California University of Health Sciences in Whittier, California. And I'm happy to talk with you today about the association between utilizing chiropractic care and use of prescription opioids. A little bit of background. In 2018, we conducted a study on New Hampshire patients with low back pain, and we found that they had a 55% lower use of opioids if they saw a chiropractor as compared to those who didn't see a chiropractor. And this study was included in a systematic review the next year by a group at Yale University. They published in Pain Medicine, and they found that recipients of chiropractic care had a 64% lower odds of receiving an opioid prescription on average as compared to non-recipients. So we followed up the next year with a study also published in Pain Medicine, and we found that patients with spinal pain who saw a chiropractor had approximately half the risk of filling an opioid prescription as compared to patients who did not see a chiropractor. And the reduction in risk was greatest among those who saw a chiropractor within 30 days of diagnosis. This was a study that expanded on our New Hampshire study and included 3 New England states. Well, the next step was to go with a national study, which is what I'm reporting here. And again, the objective was to evaluate the impact of chiropractic utilization on the use of prescription opioids among older adults with spinal pain. Our population was a nationally representative sample of Medicare claims data spanning a 5-year period. And the beneficiaries were aged 65 to 99 years and enrolled in Medicare Parts B and D, with office visits for diagnosis of spinal pain. And we assembled 2 cohorts, recipients who received both primary care and chiropractic care, and non-recipients who received primary care, but no chiropractic care. So our approach to statistical analysis, we performed Cox proportional hazards modeling to compare the risk. To reduce the effect of selection bias, we used propensity scoring, and we performed adjusted time to event analyses generating hazard ratios to compare the cohorts for their risk of filling an opioid prescription. And we did a subgroup analysis. We stratified the recipient population into 3 groups. The early group, patients whose first chiropractic encounter occurred within 30 days of diagnosis of spinal pain, and then a delayed group and a late group. So here's the characteristics of our study sample. We had over 9,000 recipients of chiropractic care, and about 5 times as many non-recipients of chiropractic care. The cohorts did differ with regard to demographics and measures of health status. And of course, we adjusted for these differences in our analyses. Now, here are the results. This is a survival curve. And in this case, survival is equivalent to going without a prescription for an opioid analgesic. The y-axis shows the probability of no opioid fill. And the x-axis is time. It's days to first opioid prescription fill up to 365 days. So this graph shows a 1-year risk of opioid prescription fill among recipients of chiropractic care as compared to non-recipients. And the recipients are represented by the dotted line, the non-recipients by the solid line. So recipients maintained a consistent advantage over non-recipients at up to 365 days following diagnosis of spinal pain. The adjusted risk of filling an opioid prescription within 365 days was 56% lower among the recipients. Here's the subgroup analysis. The black bars show the rate of filling an opioid prescription. If you look at the lowest group, the ones at the bottom, the early recipients, you can see that they had the lowest rate. So among earliest recipients, the adjusted risk of filling an opioid prescription was reduced by 62% as compared to non-recipients. So what are the policy implications here? Well, in a separate study published in Spine quite recently, we found that in a nationally representative sample of older Medicare enrollees with chronic low back pain, the rate of adverse drug events was more than 42 times higher for initial choice of treatment with opioids as compared to spinal manipulation. So we calculated number needed to treat. And that calculation demonstrated that on average, 5.7 patients would have to receive spinal manipulation instead of opioids to avoid one adverse drug event. Now, because chiropractors perform 97% of all spinal manipulation provided under Medicare, even a small shift towards use of chiropractic could be expected to reduce the risk of adverse drug events among Medicare beneficiaries with low back pain. And we saw that there were 5 times as many non-recipients as recipients. So certainly a small shift towards chiropractic is quite possible under Medicare. So what do we conclude from this study? 2 things. Use of chiropractic care is associated with dramatically lower risk of receiving prescription opioids. This has been shown consistently in multiple studies in this present study I'm presenting now, as well as the systematic review conducted a couple of years ago. And secondly, increased access to chiropractic services under Medicare may improve safety for older adults with spinal pain. Thank you so much for your attention.
We now move to the poster awards, which have been generously sponsored by the International Board of Chiropractic Examiners, or IBCE. I hope you've been able to visit our poster exhibit, which for the first time has been in digital format. With 85 peer-reviewed posters, this virtual digital format has worked really well and gives the authors the opportunity to showcase their work like never before. Poster presentations develop a research ability to communicate perceptively and concisely, an incredibly important skill in research and knowledge translation. They rely heavily on visual appeal, and the format that we've used this year in the virtual Congress has meant that we've shifted from the traditional model of a hard copy poster accompanied by the author to a multimedia presentation with embedded videos and interactive content. We have a total of 9 awards, a first and second prize for best overall posters, and 7 further awards for each of the WFC world regions. Starting first with our regional awards, the judging panel is pleased to announce the following winners. For the WFC Africa region, Dr. Marlo Swanpoel for his poster, Microbial Simulation as Education Aid for Surface Hygiene Training of Chiropractic Interns. This important study was impressively presented with a powerful use of color and pop-up video on the digital poster. The novelty of the study impressed the judges as well as its important messaging. For the WFC Asia region, Xinghu Koi for her poster, Utilization of Radiographs Among Chiropractic Interns in a Chiropractic Teaching Clinic. The judges felt that this study explored a contemporary topic relevant to the chiropractic profession, especially chiropractic education of interns. In addition, the methodology was robust and clear take-home messages were presented. For the WFC Europe region, Dr. Alan Jenks for his poster, Roland Morris, Oswestry, and Quebec Back Pain Indexes, which has better measurement properties in older adults with low back pain. The judges felt that the subject of this study was highly relevant and were impressed by the author's succinct descriptions and clear conclusion. For the WFC Latin American region, Daniel Ficini for his poster, Adverse Events Following the First Chiropractic Visit in a Corporate Environment. Dr. Ficini is to be congratulated for providing our only poster from the Latin American region. The judges felt that this poster contributed to an emerging body of knowledge relevant to adverse events following chiropractic treatment within an occupational setting. For the WFC North American region, Donna Oderna and her poster, Teaching, Learning, and Patient Care in Chiropractic Teaching Clinics During the Early Stages of the COVID-19 Pandemic in California, USA. The judges felt that the subject matter explored important and contemporary issues related to the COVID-19 pandemic and chiropractic. The resulting poster is visually appealing and used the features of digital posters to optimize communication of the study outcomes. For the WFC Pacific region, Imran Khan Niazi for his poster, Chiropractic Spinal Manipulation Increases the Corticomotor Excitability of Lower Limb Muscle in People with Chronic Stroke. The judges were impressed with the novel nature of this basic science study and the clear signal that future studies were warranted. They were also impressed by the visual impact of the poster and the well-articulated take-home message. Congratulations to each of these award winners who will receive a check for $750. Our final two awards today are the first and second prizes for the best overall poster. The judging panel evaluated each of the poster abstracts and reviewed the scores given to each during the peer review process. Starting with the second prize, which attracts an award of $1,500. I'm delighted to announce that the winner is Martha Funabushi for her poster, Characterization of Thoracic Spinal Manipulation and Mobilization Forces in Older Adults. This study examined the force time characteristics of thoracic spinal manipulation and mobilization on a group of adults aged over 65 using force sensing table technology. Judges were impressed with the scientific rigor of the study, the visual impact of the poster, and the succinct description of the methods, results, and outcomes. Our final award during this very special Congress session is the first prize for Best Overall Poster. This study examined the impact of cervical spinal manipulation using quantitative fluoroscopy. In determining this overall winner of the IBCE Poster Awards, judges commented that this highly relevant study demonstrated robust scientific rigor. They were also impressed by the use of graphics and the visual appeal as the authors clearly communicated study outcomes. This year's 16th WFC Biennial Congress, first prize for overall poster and a check of $3,000 goes to Jonathan Brainey for his poster, Changes in Intervertebral Motion Sharing After Cervical Spine Manipulation are minimal and not correlated with patient-reported outcomes. This concludes the WFC Research Awards session for 2021. Despite its virtual-only format, this has been yet another historic scientific meeting for the WFC, and we look forward to meeting again in 2023. Thank you to everyone who submitted an abstract, to our peer review committee, and to Bright Hall for their excellent coordination of the process. Enjoy the rest of the day.
To introduce the next part of this Congress, it's my pleasure to bring back to the stage the Secretary General of the WFC, Dr. Richard Brown.
It now gives me great pleasure to introduce this year's John Sweaney Lecture. John Sweaney was the third president of the World Federation of Chiropractic, serving from 1995 to 1998. Dr. Sweaney was involved with the WFC from its inception, serving on its inaugural council before becoming WFC president. He was deeply involved with the drafting of the 2005 WHO guidelines on basic training and safety in chiropractic. In honor of his outstanding contribution to the development of the global profession, the WFC established a biennial lecture in his honor to be presented by a distinguished member of the profession. Sadly, Dr. Sweaney passed away in 2019, shortly before our last Congress in Berlin. We remember him fondly and are proud to continue this lecture in his honor. This year's John A. Sweaney Lecturer is Dr. Michele Maiers. Dr. Maiers serves as the current president of the American Chiropractic Association. A graduate of Northwestern Health Sciences University, she now serves as the Executive Director of Research and Innovation at the same institution. She obtained her Master's in Public Health from the University of Minnesota and her PhD from the University of Southern Denmark. Dr. Maiers served on the board of the WFC from 2016 to 2021, rising to the office of Vice President before stepping down earlier this year to take up a presidential office with the ACA. Dr. Maiers is widely regarded as one of the brightest minds in the chiropractic profession. As a researcher, politician, and advocate, she has been honored as a mentor of early career chiropractors, although she is equally respected by chiropractors of many years standing. It gives me great pleasure to introduce Dr. Michele J. Maiers.
May you live in interesting times. This phrase that at first blush sounds like a blessing has often been attributed to a Chinese curse. While there's no historical evidence to support that claim, the phrase is often used ironically to contrast relatively uneventful times, which can feel boring or mundane, with times of great excitement, which can be exciting for all the wrong reasons. Friends, we have been living in interesting times since we last convened for the World Federation of Chiropractic's Biennial Congress. I've spent a lot of time this past year thinking about time. And like many of you, my busy life filled to the brim with work and travel, family activities, commitments on top of commitments. All that came to a screeching halt in March of 2020. My days, which before never seemed to have enough hours in them, suddenly slowed. Some days, it felt like time was actually standing still as the world struggled to get our arms around the threat of a new virus labeled SARS-CoV-2. Almost overnight, neighbors closed their doors. City streets were quiet. Patient visits were canceled. And I was in my kitchen wiping each individual grape my kids ate with a disinfectant wipe. We were scared. There was so much we didn't know. And perhaps the most unsettling thing was not knowing how much time it would take to understand the threat, what it was, how to contain it, and how to manage the illness and death it created in its wake. As Pericles said, time is the wisest counselor of all. So fast forward 18 months. How did we fare? Results are mixed. To date, the total number of global cases of COVID has reached 213 million, likely an underestimate. Deaths, 4.4 million. We don't have a good number on how many are grappling with the effects of long COVID. Social and economic inequities were magnified. Some of you may have had to temporarily close your clinic, lost your job, suffered professionally. You most certainly did personally. Many governments and public health agencies continue to wrestle with the balance of ethical healthcare policies and access, a global recession, and a citizenry whose collective consciousness has appeared at times to have been overtaken by our lizard brains. And yet, there have been brilliant moments of hope that remind us of what we are capable of. We slowed down. We checked in on one another. Neighbors supported neighbors. The garbage guy and the grocery store stocker became local heroes. Families who could spent more time with one another. I know my family contributed to the sales of board games and jigsaw puzzles, which soared during lockdown. We went outside. And importantly, we had time to just be. There has been renewed interest in lifestyle medicine and preventive health measures to reverse the trends of obesity and chronic disease that made some individuals more susceptible to serious COVID illness. International scientific collaboration and innovative technology fast-tracked the development of COVID vaccines at a rate that couldn't have been imagined just a few years ago. To date, a quarter of the world's population has been fully vaccinated against COVID. Applications to public health schools have jumped 23%. Many people took this time to take stock of their careers, their priorities, what really matters, and think about how we use this time of flux as a moment for inflection, to make changes that we might otherwise be less inclined to make. It is in this spirit that I want to frame the 2021 World Federation of Chiropractic Sweaney Lecture. Friends and colleagues, now is the time. Now is the time to ask more of ourselves. Now is the time to really understand our community's needs. Now is the time to partner with a broad range of stakeholders. And now is the time to actualize the untapped potential of the chiropractic profession. I often think about a presentation I heard in 2015, delivered by Scott Haldeman. Dr. Haldeman was the first to deliver the McAndrews Leadership Lecture, developed by the American Chiropractic Association to honor the legacy of Jerome McAndrews, Doctor of Chiropractic and well-known leader in the US, and his brother, George McAndrews, lead legal counsel representing Chester Wilk and 4 other chiropractors who sued the American Medical Association for restraint of trade and won. Dr. Haldeman provided a first-hand account of how much the chiropractic profession had changed and how perceptions of us had also changed over the preceding 50 years. He then highlighted the opportunities available to the chiropractic profession moving forward, so long as we conducted ourselves in a manner that is evidence-based, patient-centered, and collaborative in nature. Finally, he left the ACA with a challenge. He noted that the profession's challenges of the present are not the challenges of the past. We were in a unique moment of time where we needed to fully engage as participants in the evolution of healthcare delivery. We needed to be part of policy discussions, assume leadership roles, prioritize the needs of the public, stake our claim in spine care. And, he warned, the window of opportunity was closing. We had maybe 5 years at best. It was the time to act. Vivian Kill noted Dr. Haldeman's challenge during her 2016 Sweaney Lecture. And I find it interesting that both she and I independently landed on this challenge to focus our talks on. That was 5 years ago. So this seems an appropriate time to ask, have we stepped up to Dr. Haldeman's challenge? In some impressive ways, I can say, yes, we have. In 2018, The Lancet published a series on the prevention and treatment of low back pain. This was a landmark moment for the chiropractic profession for many reasons. First, it shone a spotlight on the burden of back pain. Most here are familiar with the current Global Burden of Disease report, showing that back pain is a leading cause of years lived with disability around the world. And yet, it remains less a focus in healthcare policy circles than many other conditions and special interests. While chiropractors treat a range of conditions, this leading public health problem fits squarely in our wheelhouse. A recent systematic review showed the most commonly reported reason people seek chiropractic care is back pain at 50%, followed by neck pain at 23%, with extremity problems accounting for another 10%. Many professional definitions and associations have coalesced around primary spine care, with good reason, and in response to significant need. The Lancet series was critically important not only for elevating the discourse around the burden of back pain, but for calling to task providers and healthcare systems for overutilizing low-value services, like the liberal use of imaging, opioids, spinal injections, and surgery. Instead, the series championed high-value, evidence-based services when care is needed, like exercise, advice, and spinal manipulation, which, not surprisingly to us, comprise the majority of therapies delivered in chiropractic practices. These recommendations mirrored those issued by the American College of Physicians in 2017, whose own guidelines for back pain favored the treatments more commonly associated with the care delivered by chiropractors than what medical physicians do in their own offices. What a sea change. Further, as a profession, we should be incredibly proud of the quality and caliber of the research conducted by those in our field over the past several years. Research opens doors, and the research community speaks the language so often necessary to gain a seat for chiropractic profession around tables of influence. And yes, chiropractors contributed to the teams that developed the Lancet series, one of whom has the distinction of being a lead author. The Lancet series is but one example of ways chiropractors are being recognized as experts in spine care, with experience and research expertise to contribute to the international conversation on back pain. 2018 was also the year the Global Rehabilitation Alliance was founded, whose aim is to advocate for the availability of quality, coordinated, and affordable rehabilitation to meet population needs. Optimizing function and improving quality of life through rehabilitation is central to many chiropractic practices and was noted by the Global Rehabilitation Alliance as critical for reaching the World Health Organization's Sustainable Development Goal number 3, to ensure healthy lives and promote well-being for all at all ages. The World Federation of Chiropractic is a founding member of this organization, and a chiropractor serves on their esteemed board. World Spine Care continues to grow and expand in its mission to improve lives in underserved communities through sustainable, integrated, evidence-based spine care. Chiropractors remain intimately involved at all levels of this organization, and it is one our entire profession can rally around. During the past 5 years, there continue to be chiropractors serving at the highest levels within notable healthcare policy, advocacy, and research organizations, including leadership within the Global Alliance for Musculoskeletal Health, contributors to the World Health Organization's guidelines for the management of low back pain, and the chair of the Patient-Centered Outcomes Research Institute in the US. Increasingly, chiropractors are being invited to participate in high-level discussions, to share our expertise with a range of healthcare providers and stakeholders to improve the health and well-being of the communities we serve. Also, over the past 5 years, we have witnessed the expansion of chiropractic clinical care services in military and veteran systems. The benefits of chiropractic care have been on display, helping athletes perform at peak levels in the Olympics and in professional sports. The number of accredited chiropractic programs continues to grow, as does the number of countries where chiropractic is legally recognized. During the pandemic, there are countless examples from around the world of chiropractors stepping up and stepping in to fill needs within our public health infrastructure. Chiropractic physicians in the United States were recognized as essential providers, keeping their doors open to keep frontline workers on the job, supply chains moving, musculoskeletal care cases out of urgent care facilities, and chronic pain sufferers off of opioids and other narcotic medications. The Chiropractic Doctors Association of Hong Kong provided weekly radio and newspaper announcements to share up-to-date information about COVID with the public. The Puerto Rican Chiropractic Association, having teamed up with a multidisciplinary group of providers to address healthcare needs after a series of devastating earthquakes, was recognized to provide emergency musculoskeletal care during the pandemic. Our past president of the World Federation of Chiropractic sanitized ambulances in the Netherlands. A family of chiropractors in the US became the COVID-19 emergency management healthcare directors in their region, setting up community testing centers and coordinating with local hospitals and the heads of infectious disease control. Chiropractors around the world pivoted to telehealth. Chiropractic professional organizations secured personal protective equipment, worked to combat false information, and to support our members who, in turn, support their patients. And let us not forget the scores of chiropractors who are quietly doing good work in their communities, providing high-value care to their patients, relieving pain and suffering, supporting healthy aging across the lifespan, elevating the conversation away from disease management and toward health creation. It can be tempting to focus on the negative and all we have yet to achieve as a profession. Advancement and recognition is uneven around the globe, and it can be hard to understand the actions of some of our colleagues. And it is all too easy to get drawn into arguments on social media. But instead, let's take advantage of this disruption in time before the pandemic becomes a backdrop of remember when stories, to reevaluate our standing as a profession and rededicate ourselves more purposefully to a global vision of who we are, an evidence-based, people-centered, interprofessional, and collaborative chiropractic profession. I mentioned earlier the recognition of chiropractors in the US as essential healthcare providers. While the designation was important to keeping our doors open, now is the time to ask, how well are we meeting society's expectations of essential healthcare providers? How are we ensuring all communities have equitable access to chiropractic care? Do we deliver services that reflect the full complement of our education? Do we regularly take the blood pressure on our patients, counsel patients about nutrition, movement, sleep, and stress? Are we appropriately coordinating care with other providers and connecting our patients with social services when needed? Yes, we are very good at managing musculoskeletal conditions. Patient satisfaction with chiropractic care is incredibly high. But are we doing as much as we could for our patients within the scope of practice and educational attainment to live up to the designation of essential? For many of us, the answer is yes. But for all of us, the answer is also, we could probably do more. Now is the time to take a fresh look at our community's needs and ask ourselves, what more can we, as a group of healthcare providers, do to provide essential healthcare? And whether you are viewing this from a developing nation or one that enjoys a disproportionate share of the world's wealth, I know that, as a profession, we have not done enough to help address disparities in the social determinants of health, including racism, sexism, ageism, and the uneven distribution of resources. Let us not forget, we each have a role as privileged leaders in our communities to be part of the solution. We need to listen deeply to understand the needs of others and to think creatively about how we as chiropractors can best fulfill needs as part of a team and with answers that aren't always the chiropractic adjustment. The needs of the communities we serve are always changing. Now is also a good time to ask ourselves, are our educational institutions training the next generation to meet the needs of tomorrow? Do our graduates have both the technical and the interpersonal skills needed to work in integrative settings and contribute to patient-centric models of care delivery? Are we all engaging continuing education and practice resources to leverage research and improve clinical outcomes? To discern credible and unbiased information from spin? Can we adequately and accurately synthesize the staggering amount of information that comes into our news feeds and our inboxes and our earbuds every day? And are we arming ourselves and our colleagues with skills of self-care, resilience, and other tools to prevent burnout? This is the time to lean into the incredible resources available to us to optimize the potential we have as a profession to be the leaders in the healthcare system. The path to this is grounded in equal parts critical thinking and compassion. We find ourselves at the nexus of some staggering public health problems. Economic inequities and racism have made health disparities during the pandemic even more acute. The pandemic has also amplified the magnitude of mental health problems across societies, which we still have difficulty acknowledging. In Europe and North America in particular, our population is aging at a rate that leaves us completely unprepared economically and in terms of health and social infrastructure. In countries like mine, we are seeing opioid-related deaths rise once again. And lest we forget, back pain remains a leading cause of disability. But friends, we are outside-the-box thinkers from an outside-the-box profession, and we have an incredible value proposition. Our care is safe, effective, and cost-efficient relative to the prevailing methods of managing spine-related problems. Patient satisfaction with chiropractic care exceeds that of other healthcare providers. We spend time with our patients and connect with them on a level that is the envy of our medical colleagues. This gives us the opportunity to develop trust with marginalized communities, to become a touch point for mental health intervention, and address the full breadth of variables that contribute to health and well-being. We have an intervention literally in our hands that is a biomechanical solution to functional problems and the relationships necessary to support the psychosocial needs of our patients. We can do so much to help older adults successfully age in place. The quality of chiropractic education continues to get better and better, and chiropractors increasingly find ourselves working within integrative, multidisciplinary environments. What could possibly be holding us back? Well, as with all things, the answer remains ourselves. Historically, our allegiance to the past has sometimes clouded our view of the future. But as they say, the past is made to learn from, not live in. And I would dare say the majority of us honor the past as we focus on being better practitioners and better contributors to the healthcare system today. It has been an interesting time in the midst of a pandemic to assume the role of president of a national organization. Early in my term, the New York Times began reaching out to various chiropractic organizations in the United States to ask for our profession's position on vaccines and COVID vaccinations. Given the very public disagreements of the past, there was understandably a lot of concern over who was being asked, what would be quoted, and which angle the reporter would take to cast our profession in the most disparaging light possible. But I'm pleased to say, I observed a lot of maturity and growth within the profession in that moment. I think we've learned over the past few years to either agree or disagree, but to do so without being disagreeable. Amongst ourselves, there was more understanding and grace than I expected. And at the end of the day, the dreaded article about the divide in the chiropractic profession didn't sound all that unlike what I knew to also be true across many other healthcare professions in the US. In leading during such an unsettled time, my greatest lesson so far has been the value and importance of grace. If ever there was a time to set aside our judgment of others, align instead around our commonality, and decide to lift up and showcase all that is good in our profession, it's now. Let's choose to align with one another around high standards of ethics. This is the unifying factor within the profession. Which side of the philosophical spectrum you're on has always been the wrong question to ask. That tired discussion is a profession-centric, false dichotomy that we need to leave behind us. After all, what you resist persists. And the opportunity costs of that distraction have been considerable. Instead, it is time to truly align around the highest standards of healthcare and ethics. We live these standards by being evidence-based, people-centered, interprofessional, and collaborative. The World Federation of Chiropractic's clarion call to be epic is the right message at the right time. An evidence-based practice is the bedrock of an ethical practice. The poet Maya Angelou has said, "Do the best you can until you know better. Then, when you know better, do better." To me, this embodies what an evidence-based practice is all about. We rely on our clinical expertise and that of our mentors and teachers to guide us in good clinical decision-making. We use our clinical expertise to do our best. It's high-quality research evidence that provides us with invaluable knowledge to know better. We are ethically obligated to strive to know better so we can do better. A commitment to being people-centered amplifies our dedication to patient-centeredness and focuses on what we can do to support social, political, and structural changes to enhance the health of a population. Our participation in advocacy, our commitment to diversity, equity, and inclusion, and our responsibility to deliver culturally relevant care are critically important areas of concentration for chiropractic to go beyond discussing and create actionable plans to become a more people-centered profession in the decade ahead. Interprofessional care recognizes not only what chiropractic can contribute to multidisciplinary healthcare teams, but also the value of what other disciplines and ancillary fields can contribute to comprehensive healthcare. Whether that means co-managing a case with your local orthopedist or connecting your patient with a local food shelf, successful interprofessional care places the person at the center of a team, and members of that team commit not to the tribe they identify with, but to contributing their skills and talents in a way that elevates everyone, and most notably, the patient. And finally, none of this can be accomplished without a spirit of collaboration, which requires humility, courage, deep listening, clarity of mission, and about 1 million other soft skills, which are really the most important skills for success in life. Evidence-based, people-centered, interprofessional, and collaborative. Who doesn't want to be epic? And the really exciting part of all this is that we have what we need to be truly epic. Chiropractic has the value proposition, the tenacity and the grit, the heart and the soul that is needed to accomplish amazing things. This is why, in spite of a history of marginalization and subversion, we persist, and in so many ways, flourish. The time to be epic is now, and the decision to be epic is ours. In closing, I want to wish not that you live in interesting times, but that we learn from interesting times, that we seize this moment in time to actualize our full potential as chiropractors, as healers, as leaders, and as citizens of the world. Now is the time to ask more of ourselves as we each step up within our own spheres of influence to better meet the needs of the communities we serve. Thank you.
Thank you, Dr. Maiers, for that exceptional John Sweaney lecture. As we bring this Congress to a close, I'm sure that you're all wondering where the 2023 WFC Biennial Congress will take place. Well, the wait for the announcement is almost over. But in giving you a few clues, I only have to say, good day, mention koala bears, and mention surfers, Barbies, and teenies, and you'll have a good idea of where we're heading in 2023. Let's head back to our Congress Director and WFC Secretary General, Dr. Richard Brown.
We've reached that part of the Congress where we look ahead to our next Biennial Congress. As we heard earlier from Dr. Maiers, we live in strange times, and this virtual WFC Congress has been an exceptional event. We all look forward to meeting in person once again to connect, share our experiences, and to meet outside of the classroom in an atmosphere of friendship and collaboration. Our 2023 Congress will take place October the 11th to the 14th, 2023, in the unbelievable location of Gold Coast, Australia. We are partnering with our friends at the Australian Chiropractors Association to present our showpiece event, and our planning is already well advanced. For those of you who have never been to Australia, this is an exceptional opportunity to visit this dream destination. For those of you who have been before, this is the perfect chance to return. As with many WFC congresses, we will be showcasing outstanding plenary speakers, stimulating debate, informative workshops, and groundbreaking research. Remember that as well as being a great congress, our event is the largest global chiropractic scientific meeting in the world. With platform research presentations and exciting digital posters, you will be able to meet and interact with the profession's leading scientists. This event is being held at the Gold Coast Convention and Exhibition Centre, a state-of-the-art venue just a short walk from the beautiful sandy beaches of this perfect Congress Centre. But it's not all work and no play. As well as a stellar Congress programme, we will be giving you the opportunity to sample the very best that Australian hospitality can offer. From our traditional Australian night through to our glittering gala and awards dinner, Gold Coast 2023 will be an unmissable event. Start planning now for the 17th WFC Biennial Congress. To whet your appetite and to give you a flavour of what's on offer, take a look at this short video. So there we have it, Australia 2023 in Gold Coast, October 11th to the 14th. The 17th WFC Biennial Congress in association with the Australian Chiropractors Association. Start preparing now for what will be the global chiropractic event of the year. Sadly, this brings us to the end of our 16th Biennial WFC Congress. It's been a Congress with a difference, but one which all of us at the WFC hope you will have enjoyed, and from which I hope you will have expanded your knowledge and skills. Of course, it has of necessity been a Congress with a difference. We continue to live in strange times, but times which have revealed countless examples of fortitude, resilience, and strength within the chiropractic profession around the world. The fact that we have been able to host an event of this nature is a shining example of collaboration. We have been blessed by the willingness of so many speakers to give up their time and both prepare and record the outstanding presentations that we have heard over the past 3 days. Speaking to a camera, coordinating with colleagues in other parts of the world to bring together a specialized presentation, and having the generosity of spirit to be something larger than our individual selves has been humbling. During the course of this Congress, we have learned about the power of compassion and humanitarian care around the world. We have covered subjects from pediatrics to the care of older people. We have learned about neurology, diagnostic imaging, telehealth, public health, and biomechanics. We have received the wisdom of content experts, the views of motivators, and the predictions of those with an eye to the future. To our researchers and scientists, we thank you for having shared your work, which we recognise is often the product of years of dedication, repeated trials and tribulations, and the joys and sorrows that come with research. We've heard from chiropractors, medical doctors, physical therapists, educators, as well as experts from the World Health Organization who have all shared their wisdom and knowledge. Each of our 7 world regions have participated, and for this we are truly grateful. Our virtual event has witnessed panel discussions on diversity, equity, and inclusion, shared principles within the profession, and a vision for the future. Our theme of chiropractic for a new normal has enabled us to go beyond the challenges of the past 20 months to focus on a bright future, where there are countless opportunities for the chiropractic profession. As the WFC pursues its Be Epic campaign, it is so important that within our new normal, we integrate, learn from one another, and recognise that interprofessional approaches to healthcare are here to stay. This virtual conference would not have been possible were it not for the Herculean efforts of the team at Parker Seminars. We owe them a huge debt of gratitude. The hours of recording presentations, responding to emails, to the multiple meetings over the course of this year to make this event possible, to organising CE, and for generally giving us the confidence and encouragement to host such an ambitious event has been truly wonderful. We are hugely grateful to Dr. William Morgan and everyone at Parker for having been part of what has been a dream team. We thank Ronald Legtrink at Wingflex, our professional congress organiser, for being with us throughout our aborted plans for Tokyo and Kuala Lumpur before sticking with us to support us in the organisation of this virtual event. Last but not least, we thank you, our Congress delegates, for giving up your time to be with us. Without you, we would have no Congress. You have sat with us, submitted comments and questions, stimulated dialogue, and having been present throughout these 3 days of learning and knowledge building. We hope that you have enjoyed attending as much as we have enjoyed presenting this event. Until we meet again, on behalf of us all at the WFC, I wish you health and strength to support your patients and your colleagues in delivering the very best that chiropractic can offer. Let us make our new normal a beacon of hope and success. Good morning, good afternoon, and good evening to you all.